Integrated case management is very much patient-centred. So we've got the patient in the middle there. Our patient is Valerie, but we've put Valerie's husband next to her there because we've found that a lot of the, when we're starting to do integrated case management, we're looking at more than just the individual and of course those carer needs, because Valerie cares for her husband who's got mild dementia at the moment, but nevertheless she's the main carer. So if something happens to Valerie, it affects the husband as well, so we've got two people to take into account. But our care planning is very much looking at what matters to Valerie. It's a multidisciplinary team approach around that and actually creating one single care plan that will have the top 5 or 6 things that keep her out of hospital. But we're here today to talk about the technology around that, because it's all very well and good with all these organisations coming together to say we're going to create one care plan. It's easier said than done. So most of our practices, not all of them, were using EMIS. So we developed something that I would describe to lay people as a Lego brick that sticks on the EMIS system. It's EMIS Clinical Services. It's a module that attaches to EMIS. And we can upload all the relevant GP information, and I stress relevant because we don't upload everything. So we pre-populate the care plan with a lot of the relevant information that we require. And then the teams come together around that MDT and we have access to all their systems, because all our other organisations are recording data on all their own systems, but they have access to their systems, and in real time we add to the care plan and we find out the gaps in the care. We also give access to the EMIS Clinical Services bit, not the whole of EMIS, not the whole of the GP record, but just to the care plan, to our partner organisations, to relevant people in our partner organisations. And we don't want them to upload lots and lots of care plans or falls care plans or pressure ulcer care plans or anything like that. We just want to know that if they've gone away and there's been an action from that MDT, they put a one-liner into the care plan to say they've done this, they've done that, they're actioning this. That information feeds right back to the GP, and the GP knows what's happening to Valerie in real time. We have given access to our out-of-hours providers, so if an ambulance turns up to Valerie in the middle of the night, they can see the care plan. The patient has a paper copy. I mean, we haven't got away from this yet because of the cohort of people we're looking at. The patient has a paper copy, and somebody in the MDT is tasked with being the key person for that patient, so that if we make any changes, Valerie's the first one to know and the first one to agree the changes. We do nothing without patient agreement. At the moment, we've developed these weekly MDTs to look at our cohort of frail elderly. So that's at sort of 1 to 2% of those really high-risk patients. As we're becoming more sophisticated, we're starting to think about co-locating those teams that will deal with an active CHOP caseload on a daily basis, because this CHOP caseload is like a step up. It's almost like step up care. So once the patient's stabilised, they step down again. That doesn't mean they can't go back onto the CHOP caseload. So it's a really active caseload of people going through this process. So what we'd like to do, the next stage moving forward for us, is to have a daily team that are looking at that caseload, who are talking to A&E, who are talking to the staff within the hospital, who are looking at the hospital patient tracker list electronically, and can actually start moving things around quicker in a more coordinated fashion. So for that, we're looking at all the sort of things we can do around the use of Skype and whatever else to make that easier for us. Our acute colleagues can see GP data. We're piloting GPs seeing the acute trust data the other way around, and so far in the practices we've put it in, they've found it wonderful. But we've got so many people to connect up. If you think that we're slightly bigger than health, so we've got our social care colleagues, we've got the voluntary care sector, we're talking to the police and fire and rescue, because they also create care plans for people that we weren't aware of. So, and there's a lot of work to be done with data sharing and information sharing agreements, and so that we're meeting all the information governance requirements around that. So you can't underestimate, I think, the work involved in being able to talk to one another. I think it's easier for the general public will say, well, our supermarkets, you can go into anyone and they know, but actually they're all on the one system, and health and social care, and it's very, very complicated, and sensitive information is being transferred, so we've got to get it right. I'll move on to Weightless now. We developed that with patients. Actually, we had an awful lot of patient engagement in developing the Weightless app. Now, what the Weightless app shows you is in real time all the data from all our minor injuries units and our A&E facilities across East Kent. So if you go on to Weightless, and I'll show you what the screen gives you in a minute, it will tell you how many people are waiting in all of those locations, what the wait time is, how long it will take you to get there by car, by foot, or by public transport. So we're really we're really trying to test that if we can create something electronically, can we change the behaviour of the way people are attending those facilities. We've also linked it, with the beauty of IT, we've linked it to another app, which is the Health Help Now app. So if people are going on there to find out what MIU is, they can also be directed to another app which they can put in their age, what's wrong with them, their symptoms, and it will give them options for, do you need to go to MIU? Can you do it? Can you look after yourself? Can you go to the local pharmacy? So it's actually it's about empowering people to start taking some more control of their health. That's East Kent, and they're all our minor injuries. That's the front screen of Weightless. So it is also linked to 999. So if they're, we wouldn't want somebody searching on Weightless and Health Help Now if they're having a heart attack. So we really do want them to be able to contact someone in a real emergency. So this is the sort of information that you get. So we know this was taken a few days ago. The information is uploaded every 3 to 4 minutes, so it is live information. We know at the Kent and Canterbury Hospital there were 6 patients waiting, and it was 1 hour, 2 minute waiting time, and it would take you 3 hours to get there if you walked, 57 minutes on the on public transport, or 22 minutes if you're in the car. So it uses geolocation to know where you are on the app at any one time. Now, interestingly enough, Estuary View Medical Centre, which is one of our GP practices, a big GP practice in Whitstable, 5 minutes current waiting time. So if it wasn't a real emergency and you gassed your leg or something like that, I think I'd travel in the car to go to Estuary View. So what's the impact? So we launched this at the end of last year, really beginning of this year, January. We've had over 15,000 downloads and 130,000 usages of Weightless by the end of October this year. We set out with an ambition of moving sort of 5% of activity away from our A&E units, and we've noticed at this present time we've got the 6% shift. But interestingly enough, that's a 6% shift of people with minor type injuries that have diverted from A&E to a minor injuries unit rather than going to A&E. Interestingly enough, and it sounds a bit backward, but we've also noticed a slight drop in our minor injuries units, and we think that's because they're looking at Health Help Now and using alternatives. So and this is being independently validated. We're not validating it ourselves in the Vanguard. We're using the University of Greenwich and the Behavioural Insights team, so they're providing us with that data. This is a fantastic piece of equipment. It's Wound Matrix software. Now, our local community trusts have developed this from scratch with a company in the USA. It adheres to all the national requirements for wound assessment, so it adheres to the National Wound Assessment Form. You can record multiple wounds on it or one wound. It takes a photograph of the wound, better than you could with a Polaroid camera, but also assesses the wound, which is even more important for consistency of practice. It will give you lots and lots of reports on different outcomes, so you can start comparing areas where they're, you know, and dressing types and everything else. So I'll explain it to you. So this is a tablet view. So say that person has that wound. It actually, you don't need a great deal of skill in taking the picture, so we don't have to put all our nursing teams or all our podiatrists or whoever's looking at the wounds through intensive training. You basically take a photograph using the wound matrix software. It will analyse that wound for you. It will calibrate it, it will tell you how much granulation tissue you've got in that wound, how much sloughy tissue, how necrotic it is, for example. So if I took a picture of a wound and my colleague takes a picture of the same wound, it will give you the same data. Whereas in the past, wound care has been a bit more subjective than that. I might take a look at something and think, oh, it's 50% sort of granulating, it looks so it's healing, and my colleague might look at it completely differently. So it's really about standardising and making practice more consistent to improve the quality of care. The advantage of having that accurate data is that you can keep a record of the patient's progress. So you can actually start showing people that their wounds, because some of these people have wounds that they've had them for a long time and they take a long time to heal, and sometimes they get a bit despondent with, oh, it's not getting any better. And actually, if you've got proper data that you can show someone and a graph to say it's improving or it's not improving, etc. And also it's very, very good for investigating incidents. If somebody's wound gets infected or there's an incident investigation around a wound, you've got traceable data that you can look at. So it will show you how the wound is going along, and you can show that to the patient as well. There's lots of other things you record in this, managing the exudate of the wound. Is it inflamed? How macerated is it? Is it infected, etc.? So it's more than just, it standardises practice and really keeps, as I say here, it really keeps a record, and you can get graphs from it. It will also link you to the our wound care formulary. So we've got a standard wound care formulary. It will suggest types of dressings for that wound based on the assessment from the wound matrix software. Clinicians can override that if they've got, if they feel that their clinical judgment it suggests otherwise, so they can override it. It doesn't stop people acting autonomously, but it's there as a sort of guide. So, what does it give us in reporting? We can trace all the wounds that we've seen within our Vanguard area. We'll know how many of those are pressure ulcers, diabetic foot ulcers, burns, etc. So we can record that on a more strategic level. It'll give us outcome reports with, so if we wanted to know about patients within a certain date range or a certain locality or a certain disease profile, we can get that information. It also allows us to look at areas of practice. So if we know within one of our CHOCs, the data's coming out as quite different to another area, looking at the same cohort of patients, you'd want to go in there and find out what was happening. So it allows you to have that sort of overview of clinical practice.